Hi, my name is Hannah Gilbert, and I did my presentation on tracheostomy and ventilator dependence. Tracheostomies and ventilators fall under the topic of artificial airways. Tracheostomies are an example of an artificial airway, just as endotracheal tubes are too. The artificial airway tubes are often attached to mechanical ventilators in order to aid in secretion management and breathing. The endotracheal tubes are the less common form of artificial airways due to the fact that they often contribute to laryngeal injury amongst a variety of other short and long-term side effects. Now, you're probably wondering, are these all the same? They all sound so similar. But there's a difference between a tracheotomy, a tracheostomy tube, an endotracheal tube, and a mechanical ventilator. The tracheotomy is the surgery that the patient has if they're having a tracheostomy tube placed. The tracheostomy is the opening that the tube is placed through, and then the tracheostomy tube is the curved tube that is inserted through the opening in the neck and maintains the patient's airway. An endotracheal tube, as mentioned earlier, is another type of artificial airway that is placed into the trachea to facilitate with breathing. However, the endotracheal tube is placed through the person's mouth or nose. And a mechanical ventilator is a machine that aids in natural breathing, and that's hooked to either the tracheostomy or the endotracheal tube. There is a range of etiologies that may cause an individual to need the placement of a tracheostomy tube or a ventilator to help them breathe. A person may need such a device at any point in their lifetime, namely if a medical diagnosis impacts the structure and/or the function of their respiratory tract. Some specific examples include cancer reconstructive surgeries as a result of cancers such as laryngeal or hypopharyngeal cancers, heart diseases and lung diseases such as congestive heart failure, anomalies in the head or neck such as craniofacial anomalies or tracheoesophageal anomalies, neuromuscular diseases and conditions such as in the case of ALS or cerebral palsy, trauma such as in traumatic brain injury or spinal cord injury, and upper airway obstruction such as from a tumor or swelling. The surgeon is the one that makes the ultimate decision on what is best for each unique patient. A patient may be required to additionally be hooked up to a mechanical ventilator if their breathing is compromised. This is often in the case of respiratory failure or multi-system failure. This ventilation can also be used with both endotracheal tubes or tracheostomy tubes. Now, you may be wondering why these patients need the help of a speech-language pathologist. The placement of these tracheostomy tubes and/or ventilators are often right in the middle of the neck and cause problems with swallowing and voice. Now, you may be wondering, how does a tracheostomy or a mechanical ventilator impact someone's voice? They're just tubes. Well, they're tubes that someone breathes out of because they're artificial airways. The tracheostomy is placed in your neck, in your trachea, below the level of your larynx where your vocal folds are housed. The air won't be able to travel up and build subglottic air pressure beneath the vocal folds to set it in vibration with this tube. However, there are options for a patient to effectively communicate again, and there are options for some patients to even use a voice again. One of the most common options for a patient to be able to use their voice again is via the use of one-way speaking valves. These are valves that are placed on someone's tracheostomy. Speaking valves allow the patient to inhale through the tube, and then during exhalation, the valve closes, directing airflow up past the vocal folds to create speech. If a patient uses an endotracheal tube as their artificial airway, they cannot use a speaking valve. Remember the subglottic air pressure that you need for speech? You need at least 2 centimeters H2O, while the tracheal pressure in a person without a ventilator or a tracheostomy is around 5 to 10 centimeters H2O. There are different methods to achieve such pressure in patients who have an artificial airway. Those are the two speaking valves listed on this slide are the two most commonly used in practice. Listed on this slide are different diagnostic criteria that are important to remember in patients who have a tracheostomy tube and/or are dependent on a mechanical ventilator who wish to receive a speaking valve. Tracheostomy tubes are adjusted to each patient's size and physiological limits. If the patient is wishing to receive a speaking valve, ensure their tracheostomy tube is 2/3 the size of their tracheal lumen. Additionally, the type of tracheostomy tube that exhibits the best results are the uncuffed tracheostomy tubes. During the process, the speech-language pathologist is responsible for assessing the risk of aspiration when the person's cuff is being deflated. If the patient cannot rid of secretions, additional assessment may be warranted throughout treatment. Patients may also complain of discomfort from the speaking valve. And if a patient is communicating during inhalation and exhalation while on the ventilator, you need to ensure that they are receiving adequate ventilation. It is important to note that not all patients who have an artificial airway are considered a candidate for a speaking valve. They need to be awake, relaxed, and in a good cognitive state where they are responsive and trying to communicate. Additionally, the patient has to be able to exhale around their tracheostomy tube. Also, during the placement of the speaking valve, when the patient is exhaling, it is important to be aware if the tracheal pressure is greater than 5 centimeters H2O without speech, it is likely that there is an excessive expiratory resistance. If there is an excessive expiratory resistance, the upper airway needs to be assessed in fear of an obstruction. Medical professionals can assess a patient's ability to tolerate a speaking valve by occluding the tracheostomy tube with a finger after the cuff is deflated. A patient cannot receive a speaking valve if they are at high risk for aspiration, have a decreased cognitive ability, and increased amount of secretions, use a foam cuff, or are medically unstable, along with a handful of other factors. Aspiration risk is often increased in relation to the increase in the amount of secretions. If the patient is aspirating from a large amount of secretions, they may require the trach and the speaking valve to be removed and the excess secretions to be suctioned out. If the patient does not have a cognitive ability to use a speaking valve, it will be likely difficult or impossible for them to learn how to use it safely and effectively. And cuff deflation is important for the use of a speaking valve because the cuff deflates during expiration. During inspiration, the air enters the body through the tube, and then on expiration, the cuff deflates and travels through the upper airway. As previously mentioned, there are options for a patient to be able to speak again if they have a tracheostomy, no matter if they have mechanical ventilation or don't have mechanical ventilation. The other options include talking tracheostomy tubes and a finger occlusion technique. Talking tracheostomy tubes are often used if the patient is on the ventilator and cannot tolerate cuff deflation. Finger occlusion is often used in the case if a patient has a cuffless tracheostomy tube. If the patient is a candidate for a speaking valve and they are dependent on mechanical ventilation, the following are options for them to be able to produce voice: a talking tracheostomy tube, a cuff down technique with a speaking valve, a cuff down technique without a speaking valve, and if the patient is a candidate for a speaking valve and they do not need mechanical ventilation and they can breathe on their own, the following are their options: a talking tracheostomy tube, a cuff down technique with finger occlusion of the trach tube, and a cuff down technique with a speaking valve. I know you're probably wondering now, what if the patient does not meet requirements for a talking tracheostomy tube, or they're not a candidate for a speaking valve, or they cannot utilize a finger occlusion technique? There are other approaches that may be tried, such as an electrolarynx, augmentative and alternative communication devices, such as eye gaze systems, alphabet boards, and electronic voice output systems. In the alphabet boards, they are often preferred over electronic output systems in ICU patients. Additionally, in the use of electronic voice output systems, patients are more likely to initiate communication or interaction. Also, natural speaking approaches may also be considered, such as writing, mouthing words, and gestures. The choice of which method of communication each patient uses is dependent on their cognitive state, motor abilities, medical status, independence level, and situation. Additionally, in the management and therapy, it is of utmost importance for the speech-language pathologist and other medical professionals to provide patient and caregiver education. This is because the patient's voice will often change. They need to have proper hygiene to ensure they won't get infection from aspiration. There will be changes in breathing patterns, and the patient may also notice a change in pressure. There are many prognostic variables associated with trachs and vents. It has been found that if patients cannot effectively communicate that they are more likely to have psychological and emotional problems. The earlier a patient receives services to be able to communicate again, the earlier their speech may return. Additionally, multidisciplinary teams also increase positive patient outcomes. The younger a person is, the more likely they will be able to be taken off mechanical ventilation. Having a return of voice earlier allows patients to receive better care in the ICU since they can more effectively communicate their wants and needs again, such as pain and other symptoms. In summary, trachs and vents are utilized primarily to aid a person in breathing. Those who receive a trach undergo an invasive procedure as a result of a medical diagnosis that impacts their ability to breathe. Patients who undergo a tracheostomy may or may not be placed on a mechanical ventilator to help them breathe. These are two devices that impact a patient's voice and swallowing. However, there are options for a patient to be able to effectively communicate again, such as talking trach tubes, speaking valves, occlusion techniques, and AAC devices. To be a candidate for a speaking valve, the patient has to meet a handful of criteria to ensure they will be successful. Patients on a trach or a vent who want to receive a speaking valve often have an increase in their quality of life because they are less likely to have social and emotional issues.